Bowser. She's Associate Professor and Director of MSc Program in Global Health and Policy and Management of Hiller School for Social Policy and Management, Brandeis University of Harvard. She will talk about development evidence-based health policies.
Good afternoon, everyone. Very nice to see everyone today. I'm delighted to be here, and I'm delighted to be here also because I think I'm probably the only non-clinician that's been invited to this conference. I'm a professor of global health, but I'm also a health economist. So I look at clinical practices and health policies from an economic perspective, which I think is very important in low and middle income countries and all countries around the world as we're beginning to phase into a time, as I'll show you in my presentation, where we're going to be facing some very expensive diseases that needed to be treated across very large populations. So these are the objectives of the talk today. What I'm going to talk to you about is the research that I do around health system strengthening. I'll define what that research is, and I'll explain why health system research is needed to develop evidence-based health policies. I'll use an example from a low-income country that I've worked in, Rwanda, to show how a health system assessment was used to develop policies not around cancer in this country, but around another large and growing chronic disease, cardiovascular care. And then I'll describe a health system strengthening project that we're working on in the Middle East, in 6 Middle Eastern countries around breast cancer care. So what is health system research? So this is the process of analyzing trends in what we call tracer health conditions to understand the performance of health systems, and more importantly, the gap in the health system performance, to formulate appropriate health policies. This tracer analysis focuses on mainly health outcomes, as well as access to the services needed to improve these health outcomes, the quality of these services, and the efficiency of the services that are provided. Health service research assists the policymaker in using the analysis to make system changes in some of the main areas of health systems that we focus on. And the first one that we always think about is financing. And that's because you need the financing and the funds to deliver all of the healthcare services that you need for your population. The second major area of systems that we focus on is payment. Once you have the financing available in your country, how are you going to use that financing and pay people both on the supply and the demand side to ensure that they make appropriate decisions? Looking at the organization of your system, do you have the healthcare facilities in place? Do you have the appropriate healthcare providers in place to provide the services that you need currently and that you're going to need in the future? And then finally, the regulations that need to be put in place, the important policies that need to be put in place in order to assure sustainability for your system. So in order to simplify this idea of health systems research a little bit, what I did is I created this diagram here, which is just a simple triangle. And what I tried to do, because health systems are very complicated, what I tried to do for this presentation is just to simplify it into sort of 3 main actors that we look at in the healthcare system. So on your right side over here, a key player in healthcare systems clearly are the clinicians, because individuals become sick and we need physicians and service providers in order to cure individuals when they become sick. I normally sit over here on the right-hand side of the screen for you in terms of the financing and the cost. We look at how much services cost and what are the needs, financial needs for your countries moving forward as more services are needed and more costly services are needed. And then at the top of the pyramid, probably one of the most important areas as we face more and more chronic diseases is public health, prevention, and controlling risk factors. And created this triangle with dashed lines because I would say up until this point in low and middle income countries and in high income countries as well, each of the individuals that are sitting in the 3 points of this triangle have not been working together as much as we should. And that the physicians do their job of treating, we do our job of costing, and the prevention folks work in tandem with both. But moving forward, in order to address chronic diseases, we're all going to have to begin to dialogue together to find appropriate solutions. So the reason that I say this is because the global burden of disease in countries around the world is changing. And the data here that you see in the slide is taken from a group called IHME. And they have gathered data on mortality trends in countries around the world. And you can download this data from their website. You can look at it at the individual country level, or you can look at it at regional level or global level. So I am looking and showing you here the data for the global trends and global burden of disease from 1990 until the most recent year, 2016. And you can see important changes in the global burden of disease. The most important trend that you can see is that in 1990, the largest burden of disease in countries around the world globally was from communicable maternal and neonatal deaths. So essentially maternal mortality, infant mortality, and dying of many of the main communicable diseases at that time, HIV, AIDS, TB, malaria, and other communicable diseases. And you can see over the last 15 to 20 years that the rate of communicable diseases in countries has declined. Now, in the year 2016, only 19% of populations around the world are dying of communicable maternal and neonatal, and you can see that the two largest increasing trends in terms of global burdens are some of the main chronic diseases that we're talking about here at this conference. The first being cancer, and the second being cardiovascular disease. So the two most important trends that you can see in this slide are that as of now in 2016, cancer has almost the exact same burden as communicable maternal and neonatal deaths in countries around the world. And of the largest two burdens for chronic diseases, cancers are increasing at the highest rate in countries around the world. So this is very important for low and middle income countries where financing is limited anyway, and they're trying to cover a lot of their services that they currently are covering with the limited financing that they have, and they're now beginning to tackle communicable cancers and cardiovascular diseases as well as their traditional communicable diseases. So the importance of looking at the global burden of disease is that we really, when we're beginning to look at chronic diseases across countries around the world, low, middle income, as well as developed countries, we really have to look across this spectrum of care. This is what we call the chronic disease cascade of care, looking not only at treating diseases at the individual level, focusing on illness, death, and disability, but also not leaving out of this puzzle the population level part of the puzzle, focusing on health populations and all the important risk factors that were talked about in the previous presentation. And so I would hope that when we begin to think about health systems research, that we can change the dashed lines to solid lines, and we can all begin to dialogue in solving this puzzle together for chronic diseases, looking at not only service delivery, but looking at service delivery in tandem with financing, as well as public health prevention and controlling risk factors. So essentially, the health system approach forces the policymaker to think about each health problem in terms of not only the health of the individual, but access, quality, efficiency of services across the cascade of care. It forces the policymaker to think about each health problem in terms of financing, payment, organization, and regulations needed in the health system, and analyze patterns in tracer conditions to understand how the system can be strengthened. So what are these tracer conditions? Well, up until now, because the main burden of disease in countries around the world has been maternal mortality, infant mortality, and communicable diseases, these are the tracer conditions that we've been using to measure performance in countries around the world. With more chronic conditions, we need to use, for these tracer conditions, outcomes such as incidence and mortality from cancer, cardiovascular disease, diabetes, and their associated risk factors in order to understand and improve health systems. So let me take you on a journey to Rwanda. This is a country where I've worked with a group of physicians that were treating cardiovascular disease there for individuals, mostly adolescents, that suffer from rheumatic heart disease, and they needed open heart surgeries. This is in a country where there's only 4 cardiologists and no cardiac surgeons. So talk about a health system puzzle of providing open heart surgery in this type of setting. And what these physicians would do is they would come to Rwanda for 2 weeks at a time with a team and do 16 open heart surgeries over a 2-week period. So they called me in as the health economist to help them make this program more sustainable in Rwanda, given the large constraints that they had in terms of financing, organization of the system, and the human resources. So we did a health system assessment looking at some of the traditional tracer conditions, such as maternal mortality. And as you can see here, in Rwanda, the maternal mortality rate has really plummeted over the last 25 years or so. And with reductions in maternal mortality, you can see that there was a large increase in life expectancy, which is a wonderful thing. But with increases in life expectancy, you can see, looking again at the burden of disease, that the chronic diseases in Rwanda, a low-income country, are increasing as well. Looking specifically at cardiovascular disease, you can see almost a doubling from the period 1990 to 2016 in terms of cardiovascular disease. So what we did in terms of looking at this health system is, again, looking at this cascade of care. Working with the physicians, they really wanted to focus at the individual level in terms of providing cardiovascular services to those that were ill and needed treatment. And we helped them to think more across the spectrum of care, looking at risk factors and health promotion in Rwanda at the population level, focusing on issues of financing, human resources, and service delivery. So I won't talk to you about all the results of this study, but I will show you an example of how we implemented some new policies around service delivery as a result of this work. So what we found when we looked in more detail at the referral pathways in this Rwandan system is that it was taking a long time for individuals with symptoms for rheumatic heart disease and cardiovascular disease to get to the tertiary care center. Because of the referral pathways that they had in place, the policies in the country, it was taking up to 6 months, almost sometimes a year, for individuals with symptoms to be referred to the tertiary care setting, which by that time they were at a stage where it was much harder to treat their illness. So what we did is we developed some policies around certain symptoms to allow for direct referral from the primary care level all the way up to the tertiary care center in order for these individuals to be treated at a much faster rate. So let me now go to a study that we're working on here in the Middle East. This, again, is taking a systems approach to looking at breast cancer care. This is a study that's supported in coordination with the Harvard T.H. Chan School of Public Health. They're conducting a study called the Health System Strengthening and Breast Cancer Research Study in the Middle East. This is taking a systems approach to understand the provision of breast cancer care from screening to diagnosis and treatment. And we're using the incidence and mortality from breast cancer as the tracer conditions to understand the health systems in these countries. And we're doing this study in Egypt and Oman, Kuwait, Saudi Arabia, UAE, and Jordan. So I'll just share with you some of the initial results that we're looking at from this study, and you can see here that the study countries that we're looking at here are at the bottom of the slide. And here we gathered information on breast cancer and all cancer mortality, age standardized rates per 100,000 from the year 2012, and this was publicly available data from the Globocon. And you can see here the important thing about this slide is that you can see in terms of all cancer mortality rates in our study countries, the all cancer mortality rates are actually lower or on par with some of the comparator countries that we chose for this study. But then when you look at the breast cancer mortality rates, you can see the red lines that for some of the study countries, the breast cancer mortality rate is higher than the other countries that are included in this study. We also looked at the breast cancer age-specific incidence rates for some of the country studies where registry data was available. And here you can see the different age profiles for breast cancer and for females, looking across these 3 different countries. And so I think sometimes people like to sort of make regional assumptions, but you can see here, even within this region, there is quite a bit of variation in terms of the age profiles for different populations. So this suggests that even within countries, within a region, different policies may need to be developed to address the different age profiles related to breast cancer and screening. And Oman has the lowest incidence of breast cancer for younger age populations. Egypt, slightly higher incidence for slightly older females. And the Kuwait, actually, incidence trends a little bit more like the United States. And then finally, we're looking at projections of breast cancer incidence as well in countries. Because many of the countries that we're looking at now, they're performing quite well in terms of identifying and treating the breast cancer cases that they have. But as you can see here, according to the projections that we're looking at, both the incidence and the number of cancer deaths is projected to increase upwards of 2 and 3 times over the next 10 to 15 years. So this requires taking a look at the health systems in terms of the financing available for identifying and treating these cases, the human resources available clearly for the clinical, and the prevention and screening that's available in these countries to identify these cases. So in this study in the Middle East, we're again taking a health system perspective and looking across the whole disease cascade, just like we did for cardiovascular disease in Rwanda, looking not only at the individual level in terms of the treatment, but also at the population level in terms of addressing population health and the risk factors. And for the Middle Eastern analysis, we're looking at the financing available in the system, the service delivery, also looking at referral pathways and how individuals travel through the system all the way from screening to diagnosis up towards treatment, and then finally data and management. And I think in all countries around the world, as we're beginning to face more chronic diseases, I would say that data and management is going to be becoming more and more important, and especially around cancer care, to develop the appropriate registries so that we can track and understand the disease profiles of those that have cancer in our countries. So just to conclude, as countries develop and their disease profiles become more complicated due to aging populations, demographic and epidemiological transitions, health system solutions will be needed to best address chronic diseases. New tracer conditions, such as measurements for breast cancer and cardiovascular disease, will be needed to analyze how systems are delivering care, and data and analysis of chronic disease tracer conditions, as well as understanding access, quality, and efficiency of care are essential for strengthening health systems. Thank you.
Dan, thank you very much for this great presentation. Now we are open for questions. We are open for the question from the audience. Any question from the audience? Okay.
Okay, I have a question. First of all, I'm very glad that you're coming from Harvard, the great continent. Okay. By the way, I'm practicing, but I'm chair a small initiative in Harvard Global Health Catalyst Win-Win Initiative that aim to increase affordability of better cancer care treatment. This is not far from the title of your talk. It is developing evidence-based health policies. So, in your opinion, how following evidence-based health policies could lead to lower the total cost of cancer care without compromising the overall results, or in other words, to get better value cancer treatment and care? This is going well with the title of developing evidence-based health policies.
So I think this is a really good question, and I think that this is a gap in the research that we have currently. So like I said, I'll just give an example of the research that we're doing in the Middle East around breast cancer care. We have tried to collect data on what it's costing these countries in order to provide treatment and diagnostic services and screening services. And to be honest, it's very hard to get this information in some of these countries, but I think it's going to be very important moving forward to have estimates not only of how many new cases that we have, but what it's going to take in order to treat those cases and treat those cases appropriately. So what we're doing now is we're just sort of modeling this based on data that we have from other countries and the cost of those services. But I think it's an important exercise for all countries moving forward to be able to better understand the costs of care for these chronic conditions.
Thank you.
Any other questions? Diana, I have a question for you. You mentioned that in 1990, the percentage of cancer was 12%. Then later on, in 2016, became 16%. Is this related to our awareness of the disease itself, rather than the increase of the number of the patients?
So the data that I presented is actually mortality, so it's deaths. It might be related a little bit to the awareness in terms that if individuals weren't aware and weren't diagnosed and weren't screened, then their mortality may have been higher. But I think it's also more related to the risk factors that were presented in the first slide, that we have aging populations, we have populations that are facing a lot of the risk factors related to obesity, diabetes, unhealthy habits, and so this is leading to more progression to the chronic diseases, and in many countries around the world, the services need to be increased in order to treat those conditions.
The other question is not directed to the maybe prevention, but about the cost of the treatment of cancer. As you know, that the HIV treatment before it was a little bit expensive, and there was actually from the United Nations, they lowered the price in a way that it will be affordable for everybody. Now, as an oncologist and all of my colleagues, we are getting more very, very expensive cancer treatment, including the immune therapy that will cost around like $10,000, $6,000 or $10,000 a month. So does I don't know, the global health world system will look at this in future-wise? Because this might not be affordable for everybody. I mean, maybe affordable for certain countries that has the budget to pay for the patient, but other countries might not have the budget for it.
Yes, this is also another great question. Of course, I don't have the answer. I wish I did. One of the great examples that we have of innovative financing to reduce mortality is around initiatives such as the Global Fund, and this was an initiative that was set up in order to provide expensive treatment for HIV, TB, and malaria for individuals around the world in many low-income countries. So I think moving ahead for many of these chronic conditions, we have to think of innovative ways in order to come up with financing for these expensive, very expensive chronic diseases that are going to be plaguing all nations, not just high-income nations. So we have to use examples from the past in order to come up with solutions in the future.
Any other questions? I would like to thank both the presenters for their great presentation, and we'll close the session now. Thank you very much.